Good afternoon. I'm Stephen Williams, the Director of Houston Health Department, and I want to welcome you to our COVID-19 update. This is sponsored by the Rotary Club of Houston. I have our two public health docs for Houston and Harris County. First, David Persse, who's Dr. David Persse, representing the city, and Dr. Umair Shah, representing Harris County. There have been a number of questions that have come in over the last few days, and I want to just kind of jump right into it. The first one, Bloomberg News this morning reported on a Far East country that is seeing reinfections of those who have had the virus and supposedly became immune from reinfection. If true, this is unprecedented. Does it change our idea how and when we get out of this pandemic?
Dramatically.
Yes. Unfortunately, this is what we've talked about the last few weeks, that this thing keeps changing, and we're learning more information. It's evolving. Our strategies in response are equally evolving, and so as you're hearing more about what's happening in the Far East or other parts of the world, that's also making us think about, well, geez, maybe it isn't just going to be for a couple of weeks or months. Maybe we need to be thinking about potentially immune issues for reinfection that might be several months from now. And again, a lot needs to be unpacked here, but that's our concern.
Yeah. I was not testifying, but I was speaking at City Council last week, and I said if there's one thing that this virus has taught us, and it is that every virus has its own personality and its own way of impacting the community. And so to this point, if people are really getting reinfected, so that they were infected, they got past it, they built immunity to get rid of it, and now that immunity has waned, so they're actually getting reinfected, that is an incredibly huge piece of information for us to learn about this virus. It didn't surprise me to see that in some communities where the numbers had dropped, to see as they started loosening the social restrictions, to see it come back in. That wasn't too much of a surprise, but to know at the individual basis that you're getting reinfection, that's a significant change.
It's interesting because I remember a couple of weeks ago you made a very similar comment about coronavirus, the family, that when we have flu or we have measles, there's oftentimes some sort of immunity that's built up over time. But with the corona, I remember you said this, coronavirus, it's a short-lived immunity. Right. We just don't know how long. So maybe this is that 3, 4, 5 months ago that the body just hasn't quite gotten that for a longer period of memory.
Right.
Yeah.
Well, I'm going to ask this, and I know you're going to correct this date, because I know April 30th ends the county mandated closing and federal assistance. What is the realistic expectation of expanding that date into May?
So that's that's obviously going to be a political question, and,
right.
and it seems now that with how rapidly things are changing, that April 30th to me actually feels like it's a long ways off, because so much is changing, and from one day to the next that. We're just going to have to wait and see. I think, towards late April, the 27th, 28th, and 29th are going to be some decision-making days.
Yeah. I was going to say a similar thing, that, we hired a new policy director, and she came to town first part of March. 3 weeks later, she comes back to town. She's now on board, and it's the beginning of, she's in the middle of COVID-19, a pandemic. And those 3 weeks, so much changed, and it's the same thing here, is that, you're right, 3 weeks from now feels like a lifetime, and even now when we're watching TV or movies and you're seeing individuals that are not socially distanced, you have to almost remind yourself that that movie or that TV show was shot, right. 6 months ago or a year ago, and you're like, oh, why is, Will Smith not socially distanced? Well, it's because that's not what we used to do, so right. I agree with you. The reality is that we do hope the public health piece of this is that what the constraints we put on and social distancing and, emotionally together, physically apart, that there is this hope that we can get past this sooner than later. But April 30th is really a few weeks away, and I'm really concerned that we're going to continue to have some of these enactments in place.
Yes, and I think the next question, I'm just going to read the last part of it, because I think you answered the first part, is really catching the sentiments of a lot of people. After that, it's possible to catch COVID, but then I'm feeling like a prisoner. How much longer should this continue? And the last part of that is, should compromise groups continue to stay inside?
I think absolutely. As we said just a couple minutes ago, this virus has got its own characteristics and personality, and we don't know them all yet. So I feel and I hear, and I'm a person too, and so yes, I come to work, and yes, we get to do these sorts of these interactions, but when I go home to a family that has been locked down all day, and I'm locked down when I get there. And so, we feel it, and this is a completely different lifestyle, and it is taxing. The alternative, however, is worse. So,
yeah.
I've noticed that even at city council meetings on TV, some members are wearing masks, but a few participants are not. What is your guidance on this?
Yeah. So we're sitting here now not wearing a mask, but we're several feet apart. And so I think that, at city council, although they've spread the council members out, they're still fairly close to each other. They're closer than we are right now. We know that our seats, because they've measured them, are sufficiently far apart that we're safe to not wear a mask. But I've got mine. And when we get done, I'm going to put mine on before I go anywhere. So the masks are, and as I've said at a couple of the mayor's press conferences, so social distancing is one strategy. Wearing a mask is another strategy. They complement each other. They do not replace each other. And I make that point, so if you're wearing a mask, that does not mean you can go and gather with a whole bunch of folks in the park, even if you're all wearing masks. They are complementary strategies. They're not duplicative strategies.
Yeah, it's interesting, and I don't know if I shared this last time, but my wife has an incredible debate with me when I went to the grocery store about, this is your mask, you shall wear it. And, I have it. Be honest, I'm not wearing it as much, and right now the recommendation, as Dr. Persse has mentioned, is really about you're protecting the other individual from something you have. So I think David and I, and maybe we're not right about this, but at least we have maybe a little bit better understanding of symptoms, although we know that this is the concern is the asymptomatic, the ones who do not have symptoms. So I think this is a really fuzzy area, but at the same time, social distancing is the absolute #1 strategy. So the mask is not a protection to say, let's go together and do something, because we still have to be 6 feet apart.
Yeah. So it's wearing a mask, social distancing, and practicing good hygiene.
That's right.
Yeah.
Yeah.
This has come up probably at every one of these segments. Please explain the current curve. What is the best guess on the peak at this point?
Go ahead.
Thank you.
Okay, you have less than a minute. Go ahead.
Well, very quickly, that we have seen an increase in cases, and we've been very careful to say, look, this is not just about, right now we're reporting these cases by when the health departments are getting them, that's the confirmation. But the reality is there's a lag before these tests actually come back. So this may be 10 or 12 days earlier when the actual sample was collected. So the curve is increasing. Reality is it's probably been like this, not this, but there's been a backlog of those samples coming in, those test results. So we're actually talking about, is there some way for us to go back and look at some of that curve? It's too early to say we've flattened it. It has not done this, which is good news, but really we're early in the process, and that's why the peak is late April, is what our colleagues have said. We're hoping that we can continue to delay that.
Yeah. But I always got to jump in, whenever we talk about a peak, I've always got to remind people, the peak is not the end, the peak is halftime.
That's right. Good point.
Okay. Well, we'll be right back discussing COVID-19 pandemic in a few minutes. Thank you.
$145 over 92.
180 over 111.
182 over 100. And I had a heart attack and a cardiac arrest, and then a stroke.
Your blood pressure numbers could change your life.
A lot of people don't understand, including myself, I didn't, now I do, the impact of having a stroke.
My memory is shot.
When I woke up, I couldn't speak.
If I would have followed a treatment plan, I would not be in this situation.
It's a tough journey.
Lowering your high blood pressure could save you from a heart attack or stroke. If you've stopped your treatment plan, restart it or talk to your doctor about creating one that works better for you. Start taking the right steps at manageyourbp.org.
It's a new life, but I'm gonna make it better. Coming back. Ask your doctor check your blood pressure.
My grandma always says everyone counts, and everyone who lives with us is special. Like my aunt, who took me on my first bus ride to the library, or my older cousin, who walked me to my first day of school, even my mom's friend and her baby who live with us.
The census informs funding for schools, roads, healthcare, and more. So count everyone in your home, including all children on the 2020 census. It's your chance to help them for the next 10 years. You can respond online, by phone, or by mail. Shape your future. Start here. Learn more at 2020census.gov.
Well, welcome back to our COVID-19 pandemic update. I have with us Dr. Umair Shah from Harris County Public Health, Dr. David Persse, the Health Authority for Houston. A lot of pressure on giving specific demographics, race, ethnicity, geographical areas of positives. I just want you to share your thoughts about that and what is the tug, what is the challenge with that?
Well, let me start, if that's okay, David, and please add to this. So there are two issues. I think you brought them up, you lumped them, but let's delink them a bit. One is about geographic, and one is about race and ethnicity information. So let's go with the race ethnicity question first. All of us, we're public health practitioners, we believe very strongly in transparency and health equity issues, disparities in our community. We want to know by race and ethnicity what's happening in our community. Diabetes, high blood, anything, right? We want to know that. The challenge that we have is that a lot of these lab reports that are coming back literally will say Umair Shah, date of birth, won't give you my date of birth by the way, but date of birth and a positive lab result, maybe male, female, that's it. And we then, now that we're getting dozens and hundreds of lab reports, we have to now go back and try to figure out if that individual, what's their, something about them, including race or ethnicity, but all host of other information. That's been really challenging. So that's part of the reason that it's incomplete information, or it's missing a lot of factors. On the geographic side, and this is something that I know you and I have had complementary views on this, is about this privacy issue. We want to be careful that we don't release information that inadvertently gives away somebody's privacy. So if I'm COVID positive and I live in a neighborhood, I should have a privacy protection that you don't know, not as health authorities, but you don't know as a neighbor that I have COVID positive, because that's a privacy. That's what we in this country value. Laws protect that. We've had issues with HIV and AIDS. We've had issues during Ebola and Zika, where we had individuals that were vilified even early in this pandemic. Remember, it feels like it's years ago. Just early a month ago, we were having Asian Americans who were being vilified because they were potentially positive or exposed or somehow considered that they might be at risk. So from that standpoint, we're really concerned about the privacy issue, and we're trying to balance it with the people, the community's right to know. We want to be transparent. We want to make sure the data is correct, but also that geographically it doesn't expose somebody's privacy.
Yeah. David, you and I were, before we came, we were looking at the data for the city of Houston. Right. And we found what Dr. Shah is saying to be pretty much on point. Could you talk a little bit about our experience?
Yeah, so we can only deal with the information that we get, the data that we get. And so there's two issues with the data as it's coming in. Let's talk about cases, test results from labs. So first of all, it's coming to us in big boluses. Many, many days are cohorted together, and then they send us 10 days worth of information on one day. And so then we report those large numbers. It looks like everybody thinks, well, that just happened in the last 24 hours. No, it's happened over the last 10, 12 days. But again, and to the point is that a lot of the information, as Dr. Shah pointed out, has a name and a date of birth, and you know where the lab was, and sometimes it's a hospital lab, and a lot of times it's a commercial lab, so you have a tiny amount of information to go on. Because now we got to track this. This is what's called the contact tracing. So we got to get a hold of the patient, find out their demographics and where they were and stuff, and then find out, you know, try to figure out when their symptoms began and who were you in contact with beginning 2 days before that and all that. It's a ton of work. It requires an army of people that we are currently building as we're fighting this battle. Yeah. We're building the army as we're in battle.
Is the information worth the effort?
Well, yes and no. It is worth the effort because we absolutely want to know where things are happening in our community. We want to know to whom it's happening to. So absolutely, right? If I have disparities, and you've seen in other communities where we've talked about or have seen that, you know, that African American individuals are more likely to be hospitalized, or Hispanic Americans are more likely to have an untoward outcome. Whatever the information is, I'm not saying that's accurate because it's early. We need to have that information because we can try to then focus some of our efforts. But David, I think you brought up another point which is really important, that as we're looking at this information, we're doing our best to process it as quickly as possible. The army of folks, at some point, we need to recognize that this pandemic is bigger than we have ever seen, at least in a century. And we're doing everything we can so people have to also recognize that we're also learning and we're also changing our strategies as we move along.
Right. And the other thing, as you were talking, reminded me, is that another problem with our data is that it is dependent on where the testing sites are. So that there are areas of the city where it appears that there may be a lot of COVID cases, but when you overlay the testing sites, you realize, well, those people, there's a lot of cases there, apparently, because there's a lot of testing opportunities.
That's
Whereas
right.
in other neighborhoods, there's less testing opportunities, so the numbers appear smaller. Was that because there's less virus there?
That's right.
Or just fewer people got tested?
Right. That's right.
So it's an ongoing challenge.
It's an ongoing challenge, and yet we know that we want to do whatever we can to give our community information, because I want to go back to our earlier point that we absolutely, as health professionals, public health professionals, we know that health equity matters, and we want to know the demographic information. We too want to know that information, and when you see a chart that says undetermined or still impending, and it's like 40, 45, half the people, 45%, you don't have the information, what useful information are you giving to someone else? We too want to know that information, but it's just not the way we're getting it.
By the way, ours is more than 45% unknown.
Yeah, and now ours was 40 to 50, so exactly that's the issue. It's not just our issue. This is a global issue that's happening in our country.
You know, I think one thing that's unknown is when people see that information from other communities, they have one line that qualifies it. It says that the information is incomplete, but they don't say that we're only giving you information on half of, in this case, the positive cases.
And whenever you have incomplete information, by definition, you have a reporting bias. So there is a skew in what you're going to try to interpret it from that data, because if, let's say, for example, certain testing sites are pretty complete in the way that they fill out the data, and other testing sites are less complete. So there's a difference between those testing sites. What is that difference? Because that is now, whatever that difference is, whether it be philosophical or even just operational, or maybe it has to do with the amount of money that they've got to put to work, that now has gotten into your data.
That's right.
Which you need to make sure you don't pull out in an interpretation, which is...
And I want to bring up another point, which we're trying to address, but we have that online screening tool. We purposefully did not put that information in, because here's the flip side. If we had said initially that please tell us if you're Black, Hispanic, Asian, white, etc. in this tool, we were concerned that somebody might think that the reason they were not being screened forward was because of their race or ethnicity. So here's why it becomes so challenging, that we're trying to do our best to be fair and equitable to our community, and then we have the other alternative, which is that people then start to say, well, therefore you don't care about it. That's not the issue. It's we're trying to be very careful about it. Not caring is different than not being careful. We want to be careful and we want to care at the same time. That's what we're trying to do.
So really, you're telling me that public health folks aren't trying to hide data?
No. if there's any discipline that is not trying to hide data, it's got to be public health.
That's right.
I had to say that because that's one of the things I've been hearing, that we're not being transparent or whatever, and I kind of smile and say, what, these epidemiologists, be real. Okay, I wanted to talk about that because that's really one of the current topics that's going around and something that people are really concerned about, and I wanted to get some clarity on it. You are really tuning in to our COVID-19 update. We'll be back in a few minutes. I wanted to spend
time. What is the 2020 census? Every 10 years, the census records everyone living in this country. It's written in the Constitution and comes in a questionnaire that counts everyone who lives at your address on April 1st. The data can be used to inform funding for services like fire stations, schools, clinics, and representation that affect your community. Shape your future. Start here. Visit 2020census.gov.
It's a short ride from your neighborhood to your naturehood. Find fun activities to do, like boating and biking, or camping and hiking, plus much more. To find a neighborhood park or green space near you, visit discovertheforest.org.
Welcome back to our COVID-19 update with our two docs from the city and the county. This is sponsored by Rotary Club of Houston. I want to acknowledge the work of President Kathy Finninger, our president of Houston Rotary Club, who is gracious enough to solicit questions from our members. We're going to get back to some of the questions that folks have actually asked us. If we truly have an illness or emergency other than a virus, how safe are we going to a doctor's office or emergency room?
So I think at this point you're pretty safe going, because the hospitals, the hospital emergency departments, the doctor's offices, the clinics, they have all changed their operations, recognizing, well, first of all, they're going to assume that anybody coming in may be infected. So they're screening folks right away to figure out who is at risk for having been infected and who isn't. And then if they think you have the COVID virus, though, you'll be managed one way. And if you're one of the patients who is not complaining of something, but you're still possibly infected, they're going to take care of you. It's just that there's lots of safeguards in place now, which, quite honestly, a few weeks ago they weren't there, but they got that squared away now, I think.
I agree.
Yeah.
Yes, I think when you go outside of some of the clinics, you can even see where they're screening outside of their clinics.
Right, right.
What is the best method to clean face masks? Can we safely reuse them, like the one in your hand? No, go ahead.
No, so this is a paper face mask, and this is basically not reused. We use about, I think most places recommend no more than 8 hours of continuous use. So, if you're working in the emergency department or if you're working in a hospital, probably one shift's worth. Mm-hmm. But if you're wearing it throughout the day, like I've been wearing it, at the end of the day, I need to get a new one.
Yeah.
I've heard from some colleagues about, and especially in other communities, where they've been trying to put things in ovens and microwaves. And have you heard this? That's not.
I've heard of people putting their mail in the microwave.
Yeah, but that's not.
But that's not
There's
gonna,
nothing scientific about that.
No,
Yeah.
it's not. Actually, yesterday on the morning news, that was a false. They got a false check.
Yeah.
Okay.
By the way, putting your mail in the microwave doesn't do anything to it except make it
Heat
hot.
it up.
You get hot mail.
We were told that there is no transfer between animals and human, but now we hear about the tiger in the Bronx Zoo receiving the virus from a human. Please comment about domestic pets.
Well, you know, still learning a lot more information about this. You know, it is a potential concern because if we've gone animal to human and now we have the ability to go animal, and then there's a concern, could that animal go back human? And we just do this back and forth tossing. I think one of the things we always have to remember that it's not just about humans. Obviously, we're always concerned about humans, but we're always trying to figure out where the reservoir is of virus. And so if you can go back and forth, like with the West Nile virus, the blue jays have such an important component to what happens. So there is a lot that's in here. I am really concerned about it from a theoretical standpoint, but I still think we need more information.
Yeah, well, you guys just put out the VHAN last night.
That's right.
That suggesting that there, it looks like it's still early, but there are a handful of anecdotal but confirmed cases of domestic cats being infected, and so we still don't know. Does that mean all domestic cats, or is it just those handful? To my knowledge, unless you know something different, dogs have not been shown yet. One dog, there was one or two dogs in China, but not a lot of dogs. Now a handful of cats. So that's got to be paid attention to. And certainly if you have your pet tiger, that we know that you need to watch out for that. Right?
That's right.
Your pet tiger, if it hangs out with the tigers of the Bronx Zoo, you may be in trouble.
Okay, we have about
so
3
social
minutes.
distancing for our tigers as well.
Yes.
No, go and hug it. What preparations are being made to create ancillary hospitals in Houston?
So I guess I'll take that on. I mean, you know, we are right now deep in planning and actually even implementation of some sort of what we call a non-congregate medical shelter, an NCMS, that's at NRG Park. It's really in the parking lot right now. And part of the reason it's in the parking lot, and the person I've had these conversations, because the rodeo happened recently. Like in the past, when we had Katrina, we had obviously Hurricane Harvey. It was 5 months after rodeo. So now it was right in the middle, so the air still needed to be cleaned out and all that. So we're waiting for that to happen. And in the meantime, we couldn't wait to get this very difficult to find. It was actually one of the last resources in the country to get that in. But these are always, as we've talked about, Plan C. I mean, really, Plan A is that hospitals do everything they can within their hospital to surge. Plan B is to do non-traditional ways within the hospital and or outside of the hospital. And then Plan C is really to say, if the hospitals get overrun, let's hope they never do, because everything the community is doing together to social distance and flatten the curve, then we have a Plan C.
Yeah.
Okay, go ahead.
And the point about Plan B, hospitals are doing a lot that we're hearing about to expand their capacity. And for example, at LBJ, they've got a new process when patients are brought in by ambulance. In Memorial City, there's an article in the paper and had some pictures about some tents that they built outside the hospital. Again, this is really for the emergency department stuff, but hospitals are leaning forward and coming up with. Each hospital is doing it different. I don't have visibility on each one of them, but they're working hard to come up with how to expand within their current footprint.
Not sure that you have the exact answer, but this is related to this discussion. How many are actually hospitalized at this time? How widespread are the patients in terms of hospitals? Have they created separate units to house the patients?
So I'll take a crack at this. We know that within the city of Houston, and I don't remember the exact number, but we've got a small number of, no, I shouldn't say, it's 100 and something patients that are in the hospital. We're keeping track of that day to day. And at this point, hospitals appear to still have capacity to accept more patients, and we need to keep it there.
Okay, how accurate are heat maps?
Well, they're accurate. At least they give you the information. It's purposefully done because you're trying to give people an idea of what's happening in general within a community. But obviously, it's not as specific sometimes as others.
Okay, you have been joining our COVID-19 update. I want to thank Dr. David Persse, representing the City of Houston, Dr. Umair Shah, representing Harris County Public Health. My name is Stephen Williams. I'm the Director of the City of Houston Health Department. I wanted to acknowledge the support of Kathy Finninger, President, Rotary Club of Houston. Stay tuned for more next week.